Good morning, everyone. Thanks for joining for rounds. So today we're just going to have a whole bunch of cases that we'll work through that are kind of the theme for the day is facts or artifacts. So are these real findings or are these just a result of the ultrasound modality? So we'll work through them together. If you guys are interested in that, we will just try to put up some polls for some questions, some basic questions. So if you're interested, log into the Zoom meeting and join us and participate in the polls. And everyone in the room can just, I guess we'll just do a show of hands or something like that. Okay, no disclosures. And just so as a disclaimer, all the cases today are from our Echo lab here. So just in terms of objectives, we're going to review some common imaging artifacts. By no means is this going to be like a very comprehensive talk on artifacts. There have been many talks on the SMH Echo YouTube website. Dr. Chow's done a whole bunch of them too that you can look at that talk more about the physics. So we're just going to work through some quick cases. And then we'll, when relevant, talk about some tips. If we think they are artifacts, what could you do to try to help elucidate truly whether they're artifacts or lesions or not? And so for each case, just two basic questions, is it a fact or an artifact? And the second question, what do you think it is? I'll give you a couple options, pick one, and let's see where we go. Okay, so it's the first case. Let's give everyone a couple seconds. I guess the poll will cover part of the screen.
Yeah.
That's the only issue.
I'll put it over.
Yeah, see if you put it on. Should it help?
Actually, sorry, Dr. Chow, if you're logged in there, we can't do it.
All right, coming up. Okay. Sorry, I guess my arrow here. No. So what we're talking about, just in case it's not clear or it's not very well projected on people's phones, is this thing here. So pointing at this here. You need to exit and then come back.
So, but then that will end.
That'll end me. Okay, then don't worry about it. I guess we'll just.
Or I can leave, and then that will continue displaying.
Okay, I'll keep displaying here. Okay, sure.
It's nice.
Just want to make sure it's working. Oh, it looks like it's working. Okay, perfect. Most people think it's a fact. A couple people think it's an artifact. Let's give 5 more seconds and then we'll deploy. Anyway, we can end it. Yeah. Okay, so most people think it's a fact. All right, and then moving on to the next question. Sorry, yeah, let's minimize that. So what do you think? What do you guys think it is? Like the I'll just do a quick, because I guess most people here are just not going to be able to use the poll. So quick show of hands, we'll launch the poll there, but it just within the room. Does anyone think it's a cystic tumor?
Recording in progress.
Atrial thrombus? Does anyone think it's an Amplatzer cardiac device? Okay. Or D? No clue, but doesn't look right.
Either C or D.
Fair enough. Okay, that's fair. It does look very abnormal. Okay, I can end the poll here. Okay, so what this is a figure of 8 artifact. It's really well described in the literature now. Initially, there was a lot of confusion when we first started using Amplatzer device. What exactly is going on? Is it malpositioned? Has it moved? But as the in vitro studies have helped us understand better what exactly we're seeing here. And so from some of those studies, which I've referenced here, they use a mathematical model with in vitro models to kind of understand what's happening with the ultrasound probe. So what occurs is in certain views, when the ultrasound probe is in the coronal view in relation to the device, you have waves that reflect off the mesh of the device itself. And as you can see, as a zoom in here, the waves that hit it directly tangentially are reflected entirely. The ones that hit it at an acute angle kind of are reflected off and at lower intensity. And then the ones that hit it more at an obtuse angle are deflected away and are very less bright. So what in effect happens is the ones that hit the mesh at a tangential angle are brightest and most visible with the ultrasound beam. So what you get is what's seen on the right side here. So if you hit things at the frontal angle, if you hit the implanted device with the ultrasound probe at a frontal angle, you don't get the artifact. You just see the device exactly as it appears in the box. And in the coronal view, you hit the mesh the way that it's there I just described, and you have this artifactual creation of a figure of 8, which is a little bit faint here, but that's what this figure of 8 is here. It's important to remember this because we use these increasingly now for left atrial appendage closures as well as ASD closures, and often it can look very abnormal on ultrasound. So it's important to recognize that this is a normal artifact and it does not represent a malposition or a migration of the device. So when you think about LAA closure devices, on transthoracic echo, the views that you tend to see this artifact best is the 5-chamber view, 4 or 5-chamber view, and a modified 3-chamber view. Parasternals can be sometimes challenging because the mitral valve is not all that, can sometimes shadow that artifact, but you can get it in a modified 3-chamber view as well. And so this is just another angle, but again, here you don't really see it because the ultrasound waves are hitting it at a different angle. So if you modify the angle that at which you're scanning, you might get rid of the artifact, and that helps you realize this is truly just an artifact, not a lesion. Because if it were a tumor, that shouldn't change. Right? Okay, case 2. Video on the left side, just a still image of that on the right side with an arrow pointing at what I'm interested in. The gain is a little bit lower, so it's a little bit challenging to see. I don't know if we can turn off just these lights. It might be a little bit easier to see. Okay, there we go. Might be a bit easier to see. So that's what I'm interested in knowing, if you guys think that's a fact or an artifact. And so same thing again. It gets too tedious for you. Okay. Oh,
should have an option of, I don't know.
Yeah, between fact and artifact. I guess I generally had that. Maybe it doesn't let you do it more than once. I thought we could refresh it.
Relaunch.
Yeah. Okay. Okay. Show of hands here, guys. Who thinks it's a fact, and who thinks it's an artifact? Okay. Most people think it's a real finding.
I need more views.
That's kind of our mind. Could be.
Could be.
Yeah.
Yeah, unfortunately, I don't give you more views. That would be. Oh, that is a realistic answer. Is that you would want to look at it in more views? Okay.
You can always use more views.
Okay, what do you guys?
That's all you get.
For those of you who think it is a real finding, and it's not an artifact, I actually give you 4 true findings. Do you think it's an aortic dissection? Do you think it's a coronary artery, a coronary fistula, or a pericardial recess?
B or C.
Sorry?
B and or C.
B and or C. Okay, it's either an artery or a fistula. Any other thoughts? B? Okay. So if you guys think it is an artery, a coronary artery, which one do you think it is?
Right.
That's the right.
Okay, perfect.
It's a big right. So right is the right.
Exactly, yeah. So it is the, oh, sorry, I can just dash it here. Oh, it's there.
Okay, don't worry, I'll do it.
Okay, you'll do it. All right. No, I can't go to the next thing. Okay, so it is a right coronary artery. So this is just I took it from a couple papers here showing you the exact same image, the parasternal long axis. This is the right coronary cusp here at the top of the image, and then that's the right coronary artery coming off of it. You can also sometimes see it in the parasternal short axis view, where you'll see the RCA coming off here, and then the left main ostium coming off the left side here. And just as an addition to that, very rarely you may be also able to open up the left main stem into a bifurcation point where you can see the LAD in the intermediate. One reason I bring this up is there have been some stress echoes where they've tried to look at bringing out this image and then looking at Doppler flow within the LAD and the left main stem to see.
Okay.
Yeah, out of interest.
Wow.
It does exist. Anyway, obviously there are technical issues with that. So it's more kind of a research thing, but interesting. Okay, moving on to case 3.
But we've seen that in our NHL young people scanning.
Oh, really?
Like when it was like, I think for those of us who have done this, like anywhere between 16 to 18, when you have really good probes, you can actually follow the whole coronary artery.
Oh,
I think Dean did a lot of that, like during the time when we did the NHL scanning.
that's cool. Okay, so we're interested in is that Doppler envelope there. Do you guys think it's real? Do you think it's an artifact? Couple minutes there for people to vote. Okay, most people think it's fact. A couple people think it's an artifact. Is that kind of show of hands here? Anyone think it's fact? Most people think it's a fact. Okay, so since most of you think it's a fact, what do you guys think it is? I've given you a couple options. Do you guys think it's MR and AS in the same patient with higher velocities and lower velocities, both being seen in the same one? Do you think it's an LVOT and aortic valve gradient, both seen together? Is it a significant LV dysfunction sign? Or is it a double envelope artifact?
It's one of my favorite artifacts.
Yeah, because you told me it's one of your favorites. I'll put it in. It's actually a pretty relatively common thing that we see, so it's also important for everyone to. So it is an important finding. Okay, so I'll move on to the. Does anyone want to hazard a guess? What do you guys think? What it is? A, B, C, or D? B. Okay, yeah. So that is what it is.
Yeah.
Oh, sorry. I think sorry. C. Oh,
The poll says B.
the poll says B. Perfect. Okay, that is exactly what it is. It is the LVOT and aortic valve Doppler both seen together. They have done TE and TT studies both to try to look at whether the LVOT, which is the denser, smaller jet, and the aortic valve jet, which is a larger, less dense jet, can translate and can be used as a single envelope to understand the AVA. And it turns out that it's pretty good LVOT grading and aortic valve reading, that just a single image alone is a relatively reasonable estimate of the aortic valve area. I think we should still use as much information as we can. There are better LVOT dedicated views, but you can use this if you don't have any other views. Okay.
So one of the very useful things is if you actually see the double envelope artifact, if you go back one, you see the initial one is the V1, the second one is the V2.
Yeah.
If you see it that well, and it's seen sometimes in about 30 to 34%, 30 to 35% or so, I'm like guesstimating, and you can actually do DVI on this.
Mm-hmm. Right. You just take the maximum velocity from both, or even the VTI. Yeah.
So you have a POCUS device where you could have CW, and there are POCUS devices who do this. You can actually guesstimate the degree of severity just by using one shot, without having to worry about the LVOT or in prosthetic valve. That could be a very useful sign.
Yeah. Okay.
How would you know that's not LVOT and mitral regurg?
So obviously, in this case, I'm cheating a little bit by not giving you more views. So you would obviously have that in a realistic scenario to know whether there are significant MR. The other thing that's helpful is the shape of the contour and the timing of the contour. So does it start after the opening click and end before? Whereas the MR jet starts a little bit earlier and depending on the mechanism can end a little bit later. So that's one way. Contour is the other way. Other views is the third way. Velocities, I want to say velocities is a fourth way. So if in a patient that has both MR and AS, the MR velocity should be higher than the AS velocity. But of course, you'd also want to look at the valve because you could have significantly high velocities with AS as well. And anyone else, if they have any other thoughts on it, please chime in as well.
Good. Oh, that's good.
Yeah. Okay, this is, I think we've presented this a couple times today, during rounds, but it's still an interesting finding. What do you guys think this is? Fact or artifact? Sorry, Flora, I know it's a bit tedious for you.
Another one of my favorites.
It's another one of your favorites? Wow.
It was actually in the LinkedIn once.
Oh, okay. Okay.
There are better versions of this.
There are, yeah. But I had to find one that we had from here recently, which, yeah.
So this is commonly seen in the LBOT when you do either PW or CW, and
yeah,
usually seen in diastole.
Can be seen in the mitral. In this case, it was the mitral, but can be seen in the tricuspid as well. What do you guys think? Show of hands, or just generally, do you guys think facts or more likely an artifact? Artifact. Okay, people seem to think artifact. Okay, in that case, what do you think it is? I've given you a couple of options. Is it a Doppler signal associated with contrast? Is it a tiger stripe artifact? Is it a broken ultrasound probe? Gotta get rid of this, get a new probe, it's not working. Or is it a sign of severe MS in this case, the mitral valve that we're talking about? B? Okay, most people agree it's B. Tiger stripe artifact? Or did I just make up that name? Tiger stripe.
It's a very well-informed audience.
Yeah, everyone's bang on here. Okay, yeah, so it is a tiger stripe artifact. Caused by high amplitude Doppler signals associated with highly oscillating structures. Interestingly, the first band that you see of the tiger stripe, which is the lowest frequency on Doppler imaging, represents the actual fundamental frequency of the lesion. Everything else is the artifact that's caused as a result of the high amplitude oscillation. There is a differential for it. Generally, it can be as a result of significant valve regurgitation, a flailing segment of a valve, or even Lambel's excrescence, which can be seen in the aortic valve most often, but other degenerative strands can also cause it.
You guys remember which echo fellow presented it for the first time at Echo Rounds?
So,
Yuri Franklin. Oh, is that right?
Yeah.
So maybe I'll just add. So first of all, it has to be a white tiger, like the ones those are finding in Las Vegas, to actually fit that description. Otherwise, it could be a zebra.
It could be a zebra stripe. So I should also be positive.
But in the literature, it was actually tiger stripe, and originally it was described associated with frailed or broken prosthetic aortic valve leaflets. So initially, when this sign came out, it was associated with prosthetic aortic valve dysfunction associated with severe aortic insufficiency. So one of the explanations is when the leaflet flutters, it actually creates frequencies in octaves. So that's why you see the stripes actually in multiple intervals, which are regular. So that's actually the typical features of this. However, it is found that you don't have to have prosthetic valve dysfunction or frail leaflet to actually have this. So we actually do see that quite often, especially in prosthetic valve, especially with aortic valve. It's just a leaflet oscillating, creating the vibration and the harmonics of the frequency, multiple frequencies. A very interesting observation.
And it has a sound.
It has a sound, yes.
Yep.
Yeah. One of his staff reported it. It's supposed to have a seagull-like sound. What if it sounds like a Canadian seagull? It's supposed to be a seagull sound. Anyway. All right, so case 5. Oh, sorry, I didn't put an arrow here, but what I'm interested in is what you guys think is going on here below. Or posterior to okay, so fact or artifact? All right, majority of the people seem to think it's an artifact. You guys all agree? Artifact, okay, all right. Okay. All right, so what do you guys think it is? I guess most people think it's an artifact. So is this pericardial fusion? Is it a pleural effusion? Is it a mirror artifact? Or is it actually a patient with two hearts or a heart transplant?
Two hearts.
Two hearts.
And then it will be BS1. That's the solve.
I guess if everyone said it was an artifact, it's a pretty easy question, but we'll talk a little bit about the mechanism. So this is a mirror artifact. It's actually pretty common to see. This is from a different patient on the right side here, but the same idea. The whole point of this is that you have a transducer probe where the wave is transmitted, hits a strong reflector, which in this case is the pericardium, and then it bounces off of it, hits any other object, which could be, let's say, for instance, the posterior mitral valve leaflet. And then because it hits the object, it goes back to the reflector and then is transmitted back to the transducer. So the transducer interprets that as something that takes a certain amount of time for the wave to propagate, hit the object and come back. So although it has reflected, it doesn't recognize that, and it projects an image as if it's a straight beam all the way down, and this distance is similar to this distance. Okay, so what that means is that you get a mirror artifact where lesions or cardiac structures that are very close to the reflector will be the closest behind the reflector. Does that make sense to everyone? So hence the mirror artifact where this would be the posterior, this would be the anterior, and then so on and so forth, all the way back.
Can I add to that?
Yeah, sure.
From a physics standpoint, in echocardiography, we have actually two types of surfaces in the image. One is called scattering, when things are hit it and then it scatters all over the place, meaning that the particles are much bigger than the wavelengths. But when the surface is actually very smooth, like a mirror, that's called the specular surface. So scattering versus specular. So pericardium is a perfect specular surface. The other one that is really perfect is actually the aorta. So later on you'll hear about the double aorta artifact some other time. And so this actually creates a perfect view.
So some important tips and tricks. It's just that the mirror image or the projected image is more distant than the true object. It's the opposite motion because it's a mirror image. Most commonly seen in the parasternal long, but can be seen in other views as well, apical 4, suprasternal as well. And then the way to know that this truly is an artifact is to try to decrease the gain or to change the angle and see if that mirror artifact changes in any way. And if it does, it's clearly an artifact. Okay, so a question here. Doppler signal, what do you guys think is going on here? This is a suprasternal image of the aortic arch. Okay, so more even split here. A third of the people think it's fact, and then 2/3 think it's an artifact. Is that about what do you guys think here in the room? Most people think it's fact or artifact. So let's say fact. Couple nods. Artifact. Okay. All right. Oh, sorry. So in this case, this is actually an extension of the prior talk. Okay, I didn't give people a chance, but all right, why don't we just discuss this quickly? Do you guys think this is more mirror artifact? For those of you who said B earlier, do you think it's more mirror artifact? And for those of you who thought it was a true finding, could this be, because we're in a suprasternal view here, could this be a sign of severe AI with very quick diastolic reversal as a coarctation, or is it a sign of LV failure? Okay. A couple people thinking A. Does anyone think it's severe AI? Low reversal with severe AI? Coarctation? No. LV failure, maybe? No, not sure. Okay. Most people there thought it was A. Okay. I think once options went up, it became a little bit more evident. So yeah, so this is in this case, it is mirror artifact. So as we talk about mirror artifact, we talked about the 2D version of the mirror artifact earlier, but it can happen with spectral and color Doppler as well. So in this case, it's spectral Doppler mirror artifact. And you can see that because it's the exact same kind of size and opposite in direction. One way to know if you're not sure is to decrease the grid gain and then take a look and see if it disappears. So that's exactly what the sonographer has done here. Took a nice image, saw the artifact, decreased the gain, took another image to prove that it's a mirror artifact. So this is the same patient that illustrates this really nicely. Also not infrequently seen.
So how does that actually occur?
And what's the mirror?
Where's the mirror?
Where's the mirror?
So my understanding of it, and I'm sure Dr. Chow has lots of physics behind it. My understanding of it is it's a result of the ultrasound probe frequency and the frequency of the flow of the blood and the way it hits the blood. And then it's a imaging artifact created, well, for the color, for example, it's an imaging artifact where the color Doppler's gain and it is less than that of the ultrasound probe, the black and white ultrasound probe. And so you get color bleeding. That's kind of the mechanism there. It's a similar mechanism with the Doppler, but I'm guessing there's a more scientific explanation, which I don't know. That's the best of my understanding.
I hate to admit, I actually don't know this one.
Yeah,
in terms of actually
I think the color one is a little bit known, but if anyone in the call or anyone in the room has more they could share about it, I'd be happy to hear. I don't know much more. I know the color one we understand a little bit better, but if anyone knows more, I'd be happy if somebody could share that or chime in.
Yep. When we posted comments in the
or please post a comment in the YouTube channel.
It's a GE machine.
This one's a GE. I had to crop the top because of.
It's hard to tell whether it's a mirror artifact, but sometimes the when you see color gene, sometimes there are colors that doesn't reflect the normal. So that's bleeding. Or bleeding.
Yeah, sorry. So if anyone couldn't hear, Veen was just mentioning that in GE machines, you tend to see bleeding color artifacts quite commonly where the color doesn't respect the flow and can go outside of the flow. But it's more commonly seen in GE. And if anyone has more, they can please feel free to chime in.
Is it CW? It would be true and bad because sometimes it can cut one of the branches. Right. It's a CW.
Oh yes, yeah. Is he just mentioning here that if it's a CW, you want to double check where the wave is projecting because it could be a sign that it's going into one of the side branches. So it could be a real finding. Okay, case 7 here. So a moving image on the left, and then it's just a still image. And what I'm interested in is this lesion pointed out with the arrow. What do you guys think this is? And I'm just going to move it along to factor artifact. The question is factor artifact, but I'll just play the video in case it's helpful for people. Okay, most people think it is a real finding. Is that the same here? Everyone thinks it's a real finding, not an artifact. There is a very bright pericardium there. Okay, so looks like most people think 90% think it's a real finding. Okay, that's good. So let's move this along. Okay, so what do we think it is then? Is it a loculated pericardial effusion? Is it the aorta? Is it a pleural effusion? Or is it the spine? I could add an E, I'm not really sure. It could be multiple things. Some people think a loculated effusion. Most people think a pleural effusion. A couple people think it's the aorta. Even fewer people think it's a spine. What about here in the room? Do you guys think it's a loculated pericardial effusion? Try to see if anyone's nodding. No? Okay, aorta? Does anyone think it's aorta? No? No one seems to be nodding. Okay. Does anyone think it's a pleural effusion? Few people nodding, maybe, maybe. Okay. Does anyone think it's a spine? Yeah. Okay. I will admit it is a bit of a trick question because it's not a classic location. What I'm giving you here now is a more deep shot, which obviously you would have had before you had this view, right? Clearly treated and just didn't give you that view. But with that view, what you notice is there are two things, and you're not really sure which one could be potentially the aorta or which one could potentially be the spine. They're kind of both pretty circular looking. The shape is helpful because the aorta should be more or less pretty circular. There could be some plaque in there that can make it a little bit jagged, but overall it should be pretty circular. You may or may not actually see it pulsating. But what's helpful in this case is the shadow that you see behind the lesion. So in here, you see a clear shadow, and here you don't. The shadow sort of helps you understand that this is more likely a dense structure like bone. So that's the spine. And this is more likely the aorta. So generally, this patient does have a slightly distorted anatomy. Their aorta has a slightly different course. And they had their spine is also not entirely normal in its course. So you do tend to see the aorta in a more superior kind of area. But in this patient, it so happens that this is where the spine is and this is where the aorta is. And so it's just a helpful finding because sometimes the spine is pretty prominent and there's a clear shadowing behind it, and you're not always sure is this pericardial effusion, is that the aorta?
Population.
So yeah, what you mean over here?
Yeah.
It's possible that they do have a bit of a small pleural effusion. I know I gave you guys that option, but actually this could just be a mirror artifact too, because but I think it's a loculated pleural effusion. Yeah.
I know about Lockett's pleural effusion.
But it's a pleural effusion, yeah. So I know I gave you guys that option, but what I was pointing at was the other one, and so that's the aorta, but there is a pleural effusion. So if you get pleural effusion, you're kind of right, but not the right. No, where it is a finding. So there we go.
It's not, try not to drink.
Yeah, try not to drink. Yeah. I don't know if you.
Yeah, no, as we actually can see the spine fairly often in these, especially in really thin patients. So, and as Ashwin mentioned, it's really the shadowing that. So, and you will see the patients with scoliosis and other spinal abnormalities. I don't think this position for the descending thoracic is that unusual. It's just there's a common pleural effusion that kind of
makes it.
Yeah, it kind of throws you off a little bit.
Right.
With the dilated too.
Yeah. So is it playing again? Okay. Okay, so this is just want to give you a little bit more of a zoomed in view here of what I'm interested in here. This one, I'll admit, is a bit challenging because there are ways that you would want to have multiple views here, and it may not project the best on people's phones or on the screen here. But we're going to work through it a little bit. So do people think this is a fact or an artifact? And I'm actually just pointing at the whole structure, not at that specific line, if people are pointing at the line, pointing at the structure. This whole thing here. I think most people are saying it's fact. A couple of people think it's an artifact. Okay, let's move on. So if it is, I think most people agree it's a fact. Okay, in that case, is it a ball and cage type of mechanical valve? Is it a single disc mechanical valve? Bileaflet with a lot of shadowing. And possibly two lines there that could indicate a bileaflet, or could it actually be a mitral valve ring with a mitral clip in the middle, causing some artifact? Sorry. Let's move my red pointer over here. And in this case, I'll give you some more information. But What do people think? Do they think it's a ball and cage? Pretty rare to find these days, but occasionally passes through our lab. Single disc, mechanical. That's again also rare, but bileaflet. Does anyone think it could be a bileaflet mechanical valve? Okay. As in you're pointing saying it's number one, or okay. Maybe. Okay, A. And then could it be a mitral valve ring plus a mitral clip with in the middle causing that artifact?
There's no more views. Let's see.
Yeah, Grace, this is that's the real answer. I would give you. You would obviously have many views. So kind of an even split, maybe D, maybe A. So this patient gets contrast, which is always helpful in this sort of scenario. And now you see this. So does that change people's thoughts? What do you guys think it is? Yeah, okay. So it looks like pretty unanimously everyone thinks it's a ball and cage. It's exactly what it is.
Yeah.
So you kind of see the image here. So you can see that clear movement of the ball. There is some shadowing, of course, and some bright aspects to it, but this is a ball and cage, which is obviously quite rare, but not, we do see some of them. And so this was from our lab for a patient who had it put in obviously several years ago, and it's doing well. So
several.
Yeah, more than several. It would have been like what, at least
3 decades.
Where is the ball?
yeah, so this is a question for, does anyone know exactly where that ball would be and what's causing some of this shadowing artifact? Because it does make it challenging to know exactly where the ball is. So do people think the ball is sort of here, or is it here, somewhere in the middle?
You know it's on the LV side. So.
Yeah, so I think we know from looking at the actual model of the ball and cage valve, we know it's in the LV. And so what happens is you have a ball up here that moves further into LV to open the valve, and then comes back and closes back into the atrium. So it goes back into the annulus and closes it. So that's the way it operates. So everything you see behind it is basically shadowing.
And artifact.
You see, the cage, tip of the cage doesn't move.
Right.
Yeah, and that's what you saw in the 2D image.
Yeah, so I just go back to the 2D. Maybe we can also just look at that again. Sorry, just going to play the bigger version. Maybe. Yeah, so this part here doesn't move, but it's hard to see that moving shadow here. But if you look very closely, there is that movement right there. So that's kind of what tips you off, but it's hard to know. That's why contrast in this case is very.
And we'll hardly see them anymore at this point.
Yeah.
We saw a lot of it in my early part of my career.
Right.
Here in the first 10 years. We used to follow a lot of them. We have them in our clinic as well. So their physical exam is very, very unique.
Yeah.
I think Trevor had a number of patients with that. Sorry.
I think the ones that survived were metal. The ball was metal because they actually, for a while, made the ball out of some sort of plastic, which kind of deteriorated.
Silastic
and fell apart. Whereas the metal ones lasted forever. So you get the reverberation off the front and the back edge of the metal ball.
Yeah, right.
So you get that ring down into the LA.
The development of this valve is also very interesting. One of the two names involved, one is a physician, the other one is an engineer. So they got together and then come up with one of the first valve that actually can work for a long time. And some of the patients that we follow lasted for at least 35 years.
Yes. I'm not sure how well this sort of projects here, but
you're asking for the name? You didn't give the name.
Oh yeah.
No, I had it in my thing, but one is Star Edwards. One is Edwards. STAR. Yep.
Yeah, the surgeon was Albert Sommer. So Portland.
So these worked really well with mitral regurg. They didn't work at all well with mitral stenosis. And the problem was the ventricle was small. In a small ventricle, the problem was the cage is so high and the ball's so big that it actually, when they put it in, it stuck into the septum. And a lot of them ended up with the cage actually was embedded in the septum, so the ball actually couldn't open properly, and would be partial. So it was stenotic still, it didn't open, and would be sort of obstructive in systole because it was sitting right across the LVOT. So it was a big problem with mitral stenosis type patients. So that's when they invented the Beal, the low profile.
Which is another story on its own for the next episode.
The next
Doesn't last
episode.
very long.
Yeah, it didn't last very long at all.
So this here, it is a 4-chamber view, apical 4-chamber view, and what I'm interested in is that lesion there, the bright spot here. Do you guys think that's a fact? Do you think it's an artifact? Also relatively common to be seen, pretty prominent in many patients. Okay, pretty unanimously, everyone thinks it's a fact. All right, and if so, what is it? It's kind of long, linear, and thin. Is it a fibroblastoma? Is it a Coumadin ridge? Is it a reverberation artifact? Could it be a side lobe artifact? The linear line going right through the atrium. Okay, I think most people here agree. It's a Coumadin ridge. Okay. So I won't spend too long on here. It sounds like most people recognize this. So yeah, this is a classic appearance of it. It's just a slightly better example. So you get to kind of see the bulbous part of the Coumadin ridge at the edge with the more thin linear part behind it. So it's basically just a embryologic remnant formed by the ridge. It's a ridge that's formed between the left upper pulmonary vein and the left atrial appendage that causes a fold. And the reason why people call it the Q-tip sign in TEE is because the proximal part is thinner and then the distal part is more bulbous and looks like a Q-tip, essentially. So that's the Q-tip sign that has been used in literature. It contains an autonomic nerve bundle. It contains a sinoatrial node artery. It also contains a ligament of Marshall. And just a quick thing: does anyone know how it got the Coumadin ridge name? Yeah, so it's because it was such an abnormal looking finding. Often it used to be misdiagnosed as a left atrial thrombus, and patients were started on anticoagulation. And so subsequently, after we recognize it and understand it a lot better, we now know that it's a normal finding, it's a Coumadin ridge, and that it no longer is something that requires anticoagulation. So that's how it initially was.
Yeah, I heard sometimes there were times where patients would be taken to surgery just because it was so prominent, it looked like a tumor. Yeah,
I never saw that.
but I heard about that.
What your surgical story made me think of is in the very early days with a mechanical mitral, there were situations where the left atrium was full of reverberation artifact, and they thought it was, so they actually sent some of these patients to surgery because they thought LA was full of clot. Before we understood what reverberation was.
Right.
So it's
Yeah, and this is just how it looks.
the downside of early echo, right? Caused some problems.
Early learning.
Early learning, which was not good for the patient.
Yeah, so this is just a surgical specimen that shows it to here. It's a ridge. Okay, try to get through the next couple of them pretty quickly, just because there are some interesting ones at the very end, and just in the interest of time. Okay, sorry. Do you guys think this thing here is real, or is it just an artifact? It's projecting it. Okay, yes. Real. 2/3 saying real, 1/3 saying maybe artifact. Kind of the same here. Some people think artifact, or does everyone think it's a real finding? I'm not sure. More views. More views. Yeah.
There's 50.
Is there speed? If you do think it's real, is that like a mass attached to the aortic valve? Is that just the aorta? Is it a reverberation artifact, or is it a small mass like an atrial myxoma? I admit, again, you would have way more views. You wouldn't only have this one view. So see, this is not realistic views, but
So the guess is fairly even this time.
yeah, the guess is fairly even. So this is a interesting echo, because you see this, and then there's a couple of different views of this, but essentially what it is a patient who has quite a bright aorta, aortic wall, probably a bit of calcification in it, and enlarged LVOT. Now, obviously, the LVOT is here, but this is just the extension of that aortic wall and the LVOT. So, not a uncommon finding. You'll start to notice that this is visible in some patients. So, what this is not a clear four-chamber view. You're kind of opening up the LVOT in a five-chamber here, and you're just seeing a bit of that wall in the back, off plane. So that's why it looks a little bit funny.
Well, I also have a plea because sometimes I see this, it's between 5 and 4, and someone actually take a picture of it, and then we'll spend a lot of time trying to figure that out because often the aorta actually comes out and when you only cut part of the wall, it becomes like a mass in the left atrium or somewhere around there. So, or right atrium. So, like if you actually do see it and you think as a sonographer, this is not a mass, and after you had the privilege of scanning through it, please don't record that picture because it gets very confusing. You have only one.
That's exactly what they did here. They saw this, and then there's many views since they kind of look at it in different angles, and it's very clear. It's just a fine chain. There's no mass.
When you record these pictures, you have to remember how your reader is going to read it in that context. It can be very confusing. I've actually struggled through quite a few of these over the years.
Actually, one of the things that helps for the sonographers is they do a sweep. You see something weird like that, do a sweep. Then it's sometimes becomes very clear on the sweep.
Explain.
Yeah, no.
Or an X-
use of the 3D poll with Explain really that definitely adds.
Now, way back when I missed the videotape because when you record it, you actually will have the sweep because the patient actually breathe in and out, and you can actually decipher that. You actually get more information on the videotape way back when.
So this is how well this one projects. It's quite grainy, but the sun just came. Yeah, and the sun just came out. I might skip this example just to move on to some. No, because there are some interesting ones. Okay, that's fine. People started answering already. People think it's a fact. All right. Some people think it's an artifact. About the same here. Everyone thinks that that's most likely a real finding there at the top. Yep. I don't know if you guys can see it at the very back. It is quite grainy. It is a bit bright.
No, you can see it.
Oh, there. Yeah. Okay. If it is a real finding, what is it? Is it the pulmonic valve? Could it actually be the tricuspid valve? Is it a Chiari network? Or is it a mere artifact from that aortic valve right below it? Fair number of people think it's the tricuspid. Okay, no, pulmonic is now the predominant answer here. A couple people think it is a mere artifact from that aortic valve. What do people here think? Pulmonic valve? Yeah? Okay.
Pulmonic.
Mirror artifact? No. Okay, I'm going to skip over because I want to get to some other examples here. So yeah, this is the pulmonic valve. Very close proximity to the aortic valve. So if you think this is a TE image on the right side here. So if you look at where the aortic valve is here, it's immediately lateral and anterior to it. So that's how you're catching it. So in parasternal lung, it's not infrequently that you can catch the pulmonic valve. So if you actually play around with the parasternal long axis view, pointed more anterior and pointed a little bit more lateral, you can uncover the pulmonic valve. So that's just the pulmonic valve. And the clue here is this is the RVOT pulmonic artery there. Okay, we kind of talked about this already, so I'm going to skip over this so we can get to another nice example. This is basically a good example of what we talked about earlier, a mere artifact with color bleeding. This is a G machine, as Veen had mentioned. More commonly seems to have
No,
this.
this is Phillips.
Oh, is this a Phillips?
Yeah.
Oh, sorry, this is a Phillips. Well, I guess it works at both. Two Veens, yeah, you're right. Sorry, yeah, I'm just noticing the format here. But yeah, it says P right at the top there. But anyway,
It occurs in all.
it occurs in both. It occurs in all machines. So what this is
It shouldn't occur in everything. It's
Yeah.
Yeah.
But what this is color bleeding mirror artifact. It's also called blooming artifact. There's all sorts of names that people have described it in. And so the real true flow is obviously within the aorta and the walls of the aorta, but you have bleeding of that color into the other side here.
It is also known as the double aorta artifact.
Double aorta artifact.
Because what happened is the aorta becomes the mirror. As a specular surface occurs around 60% of our cases, depends on the wall of the descending aorta, what's the incident angles between the beam. Anything that is less than 45 actually will create that artifact. Anything more than 45 will be less likely to create that artifact.
Right. So just a little bit of the physics that occurs because spatial resolution of the color Doppler is less than that of the gray ultrasound wave. So that's kind of the explanation for it that I got from one of the radiology sources. And again, the solution: reduce color gain. Look and see where the true flow is. So this is a little bit of more of a challenging thing. It's a couple parts to this one. So I know we're almost out of time here. So this is a suprasternal view, and what you have on the right side is the CW and the PW. The question doesn't end here. I'm just presenting this. Give everyone a second to look at the velocities, the contours, and the Doppler. And then I have a couple more pictures.
Save the best for the last.
This one and the next one, if I can. I don't know if I have time, but we'll see.
Dr. Leon Poy's favorite.
Yeah, so this is the abdominal aorta, same patient, and a spectral Doppler from here. Now, obviously, again, I'm not giving you a lot of views, and you would have more information because you know. But in the interest of just us all learning, in the interest of our learning, we're just this is the information that I'm presenting. So just out of the question is, the spectral Doppler is clearly quite different between the two views. So how can you explain this difference in the spectral profile between the suprasternal view and the subcostal view? Is it real or is it an artifact? And I think more importantly would be the next question, what do you guys think is going on here? Okay, it's real. Okay, I just want to end it. I just want to get to the actual explanation here. So what do we think it could be? Could it be that the abdominal aorta has a coarctation? So you don't see it in the suprasternal descending thoracic, but you do in the abdominal. Could it be a sampling error of the PW? Could it be a coarctation with an extensive collateral flow? Or could it be severe AI? C, coarctation with a lot of collaterals, maybe. Anyone think it could be just a coarctation that's more distal, like of the abdominal aorta? Could it be a sampling error? This one's really hard to be definitive about, and obviously I haven't given you enough information. In this case, because this was an interesting case, and I'm also going to mention that the sonographer didn't make a mistake. This is an interesting finding we picked up, and then we asked them to do this and get these spectral Dopplers. Okay, so this ended up being a sampling error, brought to us because there's this very high flow that you see here in a small sub-branch of the abdominal aorta. So when you do put your PW Doppler right in the aorta, you get a normal flow. It's very similar to the descending thoracic aorta. But when that PW was slightly off, which can happen because it was in the same line, just slightly, the depth is a bit off, they ended up sampling that tiny vessel with the small flow. This tiny vessel with the turbulent flow, and got this view. And this is completely normal. This is how flow would be moving from a large aorta to a smaller branch. Can happen.
Someone in the chat said celiac artery.
Yeah, can happen. Not something that very feasible that it would happen. So just something to keep an eye on. Could it be that we're just sampling the wrong part? So just think about that when you the superstone on the subcostal doberty.
Intentionally did not show us.
I intentionally did not show that, so yes.
But
So you guys could be
but it did show the abdominal aorta, and you could see from the color Doppler that it was not the color Doppler and the P Doppler
didn't match exactly.
And there was
Perfect.
red flow right there.
Yeah,
So as a reader, if you don't have it, you should be able to suspect that it's an issue.
And there's the velocities are not high enough.
and the velocities weren't high, so that's all clues for why it couldn't have been really coarctation of the abdominal aorta. Which, by the way, has been described, coarctation of the abdominal aorta alone without coarctation. I know it's more proximal generally, but it has been described because I was looking it up to see is it possible when I was coming up with other options, and it does exist. So important to look at all the information. I just want to quickly, sorry, I know I'm right at 8:59. Just want to present this as an interesting finding here. This is a T of a patient with the mitral valve in question. So Doppler right through the prosthetic mitral valve to find this profile. Do you guys think that this spectral Doppler profile is real or is it an artifact? Let's try it a little bit quicker. It's okay. Let's quickly watch it. 10 seconds. That, okay. Right, and then the majority seems to think it is real. So what is it? Could this be a sign of mitral stenosis? And then you're catching a little bit of the aorta and it's aortic stenosis as well. Could it be subvalvular stenosis? Could it be normal mechanical mitral valve? Could it be reverberation artifact? Thoughts? Does anyone think it could be a sign of mitral stenosis? And then we're just catching a little bit of the aortic valve and it's a mixed Doppler. Not many nods for that. Could be subvalvular stenosis, maybe. Could it be a normal mechanical mitral valve? Reverberation artifact. Okay. So this one, the reason I say it could be possibly artifact, could be a real finding is because there's a little bit of debate on this. It has been well described that mechanical prosthetic valves, even mitral patients can have Doppler profiles that have the double envelope. People have tried to understand exactly what's going on. The initial thought was that it could be an artifact, and then they've tried to investigate this further and found that certainly the more dense jet in the center, is with the lower amplitude but more dense jet, seems to be the true mitral valve gradient, the prosthetic valve gradient. That's understood from invasive studies where they've tried to look at the double envelope and then actually do hemodynamic tracing and figure out which one's accurate. But why do they have the other Doppler profile? We're not entirely sure. There's some suspicion that it could be because you're too close. We notice that if you go right in the middle of the valve, you tend to get the denser jet only. But if you go slightly more towards the wall of the more lateral aspects of the valve, you tend to uncover this double envelope. So some people have theorized that the wall of the jet, there have been studies to show, everyone used to think that the flow in the middle of the valve is always the fastest. That is generally true, but the wall, the flow of blood right at the vessel wall also seems to have some turbulence to it. So there are some studies, I've actually linked them here, so please feel free to read them, that show that there's more of a vortex flow at high velocity right at the vessel wall, and that's what you're catching. There's another group of people who think that when you're putting in these mechanical valves, you're actually also compressing part of the subvalvular apparatus. And so what you're catching is a bit of flow acceleration right because of the subvalvular apparatus, and that stenosis is what's causing the double envelope. Not entirely sure what's the answer, but I would be happy to hear if anyone has thoughts on this.
This is a bileaflet.
In that patient, yes.
This patient is showing a bileaflet.
Yeah. Although although so this patient also had a mechanical from a study, but mechanical valve. This one here is actually a patient who had a mitral clip, just a mitral clip. So what they did is took a patient, put a single mitral clip in the middle, and then measured Dopplers on both sides of the orifices and tried to figure out when you put it right in the middle towards the center of the valve, you get a single profile. If you go slightly more towards the edge of the valve, you get a double profile. So that's where they're theorizing maybe there is a vortex flow or subvalvular stenosis.
Yes, we've seen it with native mitral stenosis.
Right.
I think you and I.
Yeah.
Sorry.
I've not seen that with a native.
I
So-
think someone did it at pressure.
Yeah, pressure recovery in the aortic valve. That's also I've heard that I saw some paper on that as well. Some people think it's pressure recovery. But if anyone on the call has more thoughts on it, please feel free to share. And we're going to end it here, but that was my last case. I'll skip over this one. I just want to acknowledge that Yazid helped me immensely with getting all of these examples. So I want to acknowledge and thank him for this. And most of the stenographers have left, but I wanted to thank them because they helped us a lot with some of the images, and of course the Echo Lab as well.